Hello, I am Ali Mokdad and I am a pediatric surgeon at Cook Children's. In this video, I will talk to you about tracheomalacia. We will talk about what tracheomalacia is, what are the common signs and symptoms your child may be having. We will also talk about tests your child may need and how we treat tracheomalacia. Tracheomalacia is often called a floppy airway. Normally, the bony part of the airway that you can feel at the front of your neck looks like a C shape sitting on its face. The back part is made of a thin layer of muscle. In children with tracheomalacia, the front bony part might be shaped more like a U or a bow, and this makes the back muscle part wider and floppier. When the back part is wide and floppy, it can block the airway and make breathing hard, especially when children cry or cough or get upset. If the blockage is bad enough, a child may turn blue because they're not getting enough oxygen. The blockage in the airway will also trap mucus in the lungs, making children more likely to get colds or lung infection. You might hear your child making a barking cough or may have a noisy breathing. Some children grunt to try to keep their airway open. Older children might notice they tire out faster during sports or develop a relentless cough after an infection. To check for tracheomalacia, we perform a procedure called dynamic bronchoscopy. This is when we use a tiny camera to look inside the airway while the child is asleep under anesthesia. The procedure involves 3 parts, all of which are done at the same time. First, we watch the airway while the child breathes slightly. Second, we make the child cough to look for more areas in the airway that are the most blocked. And third, we put the child into a deep sleep and we stop their breathing for a moment to check for anything unusual in their anatomy. We look at the entire airway, including the neck part of the airway, the chest part, and the branches going into the right and left lungs. The dynamic bronchoscopy helps us confirm tracheomalacia, figure out how bad it is, and see which parts of the airway are most affected. Sometimes we need to do more tests other than bronchoscopy. A lung doctor might use a smaller camera to check the tiny airways deep in the lungs. If there are problems with the esophagus, we may involve a GI doctor. An ear, nose, throat doctor may need to look at the voice box too. We may order a CT scan of the chest to make sure nothing is pressing on the airway. Other tests we may order are an echo of the heart to check how the heart is working, a swallow study to see if the food or liquid go into the airway, or a sleep study to check if breathing gets worse when the child is asleep. Once we know tracheomalacia is the cause of the breathing issues, then we can start treatment. We generally start with medications to treat. In cases when medications do not help completely resolve the symptoms, surgery may be necessary. If surgery is needed, we typically do a procedure called posterior tracheopexy. This procedure helps fix the floppy part of the airway. Here's how it works. The trachea or airway sit in front of the esophagus, and behind them is the bony part of the spine. In a posterior tracheopexy, we move the esophagus out of the way, and we stitch the floppy part of the trachea to the bony part of the spine. This stops the airway from collapsing, so the child can breathe better and clear mucus more easily. If the child also has an esophagus problem, we may address that at the same time. This surgery is done through an opening in the right chest under the shoulder blade. The surgery may take anywhere from 6 to 10 hours. And after surgery, all children will go to the ICU. They will have a tube in their chest, which stays for around 2 to 3 days. Our pain team keeps them comfortable with medicine. Most patients usually stay in the hospital for around 4 to 7 days. There are some risks to a tracheopexy, such as bleeding, infection, or leakage of air or fluid. While these risks are not common, children may require some extra time in the hospital if this happens. Most children feel like they can breathe much better immediately after surgery. Patients will follow up with our surgery team in about a month after going home, and they will keep checking in with the lung doctor on a more long-term basis. At Cook Children's, we have a big team dedicated to helping children with tracheomalacia. It is a combination of pediatric surgeons, lung doctors, ENT surgeons, cardiac surgeons, GI doctors, pain specialists, speech therapists, geneticists, and psychologists, among many others, that allow us to take the best care of your child.